So welcome everyone to our March 2022 edition of the Evidence-Based Services Committee Roundtable. Today we have the pleasure of having Dr. Puanani J present on using local aggregate and treatment research findings to guide clinical decision-making. We also have several esteemed panelists as well as discussants, and we will be doing the discussant introductions towards the end of the presentation. And before turning it over to Pua, a couple of housekeeping announcements, please. One is, let me see, look at my announcements. As Tommy put in, or will be putting in the chat, this roundtable presentation has been approved by the National Association of Social Workers, and I'll be speaking to that a little bit before we start. Whichever email that you use to register for today's roundtable, please be on the lookout for a feedback survey that we'll be sending to that email address. If you have signed up to receive social work CEUs, the CEUs will be awarded based on both your time in today's webinar and your completion of the forthcoming survey. You will be expected to attend at least 90%, about 81 minutes of today's roundtable webinar to be considered for awarding CEUs. However, whether or not you have signed up to receive CEUs, we would greatly appreciate if you could fill out the forthcoming survey to give us feedback on the quality of today's webinar. And let me see, a quick introduction about Pua. Dr. Puanani J completed her undergraduate work at Oregon State University and earned her doctoral degree at the University of Hawaii at Manoa's Clinical Studies Program. She's a clinical psychologist with the State of Hawaii Department of Health, Child and Adolescent Mental Health Division, and her research interests include system of care improvements and rural mental health. We have, again, several esteemed panelists and discussants, and we'll introduce the discussants towards the end of Pua's presentation at 3:45. So without further ado, if I could hand it over to Pua. Is that okay, Pua?
All right, thank you, Brad. Hi, everybody. Good afternoon. Welcome. So excited to be with you this afternoon. I'm talking to you about our use of both local aggregate and treatment research findings to guide our clinical decision making. There's several major things we'll be focusing on today. The first is identifying types of data that can help to support our clinical decision making. The second is to introduce a tool that can specifically help to inform our clinical decisions that synthesizes both treatment research findings as well as local aggregate data. And the third is to discuss occasions during treatment when that tool might be used. So first, what are some of the different types of data that can help to support our clinical decisions? There are four major types that we'll be talking about today. You can see them all listed here, and we'll start with treatment research. So thinking about what the treatment research literature says, this is an example of the blue menu of evidence-based psychosocial interventions for youth. This is a tool that helps to synthesize treatment research findings by level of support. It's currently found on the PracticeWise website. I believe Tommy has actually dropped a link to it in your chat, and it's also available on the American Academy of Pediatrics website. As you can see here, looking at disruptive behavior concerns, for example, treatment types with best support. So that level 1 best support would include things like anger control, assertiveness training, cognitive behavior therapy, contingency management, among several others. And this can be a really helpful guide when trying to take a look at the treatment research literature for particular major areas of youth mental health concerns. You might also be wondering, however, what local evidence says. And before I get to what this is specifically, I just want to take a pause. So you can see some a pretend example of locals rubber slippers in the top left of my slide. So if everybody could just navigate to their chat box, You should have a selection of sending your chat to either all panelists and all attendees. Select all panelists and attendees. Go ahead and tell me what those flippers are used for. Any thoughts there? Walking, yes. What else? Exactly, killing insects or specifically roaches. Any other novel uses? Protecting our feet. Oh, I like this one, doorstop. Great. Beach, walking, or comfort. Ooh, to look good. You must have some fancy rubber slippers, Tommy. Okay, so you're welcome to keep submitting your ideas here. But if we think about the reason these were developed, I'm just gonna go out on a limb here and say they were developed as a footwear device, maybe more for casual settings and or going to like the pool or the beach. But as you can see here, it's a multi-purpose tool actually with some local uses. So those may range from killing cockroaches to use as a doorstop. The answer I didn't actually see from anybody is, oh, that's a good one. Marking the goals of soccer matches. The answer that I actually haven't heard though, which I think is pretty common for us here in Hawaii, is for elementary, exactly, Lindsay Tom, is that you? So put your rubber slippers on your hands so you can run faster and chase master. Exactly, exactly. So as you can see here, despite maybe having a method for which this device has been designed and tested in theory in research trials. I don't really know if your average local rubber slipper, how much rigorous testing it went under, but in theory, it was developed for a particular purpose. But as we can see here, it certainly has some a variety of different local uses and probably even some that are specific to our population of folks here in Hawaii. All right, so getting back to children's mental health, as you can see here, what we're looking at is an example practice profile for youth receiving intensive in-home services within a particular example agency that are being targeted for oppositional and non-compliant behavior. This is an example then taking a look at the frequency for which certain practice elements were applied for youth with that target, that oppositional target, within our state system of intensive in-home, but also for the particular agency. And we can actually see some differences here just taking a look at this. Commands or limit setting was pretty highly reported within our state population of youth in intensive in-home. And we see that it's also fairly highly represented here with within this particular example agency. We also see some differences though, right? There's some other times where there may be a practice element that's applied frequently. So the next one here, communication skills, and maybe still offered, but not as highly within this agency. But this is an example of some local data that we can see within our state system and even within a specific pretend agency. So in addition to looking at treatment research data and local aggregate data, we might also look to client-specific data as well. And so this could be both through a standardized assessment measure. This is an example of child and adolescent functional assessment scale measures that were completed for a youth across several administration time points. In CAMD, this is routinely administered approximately quarterly for our kiddos, and it measures functional impairment. So again, client specific, maybe a standardized measure, or potentially something more idiographic and related to what is being focused on in treatment services for that kiddo. So perhaps for youth with mood-related concerns, perhaps that therapist is tracking youth's mood ratings over time, or perhaps for a kiddo who has been in school refusing, a therapist is tracking number of days attended school each week. So now we're up to treatment research, local aggregate, client specific, and last, we might also be taking a look at essentially clinical judgment of treatment team members, but also really taking a look at the causal mechanisms that we might be exploring related to the youth trajectory, considering developmental psychopathology for that youth. So really, what does the team's memory, professional judgment, and expertise say about what's going on? So great, there's all these different forms of data that you can be looking to help to support your clinical decisions. Now, you might be wondering, is there a tool out there that can help me to synthesize research and local data for our kiddos? And yes, there is, and yes, I'm getting to it. But I'm gonna give us a brief example before we get quite there yet. So I think folks have heard this example a little bit before when we've talked about some of these tools. So thinking about chocolate chip cookies as a metaphor for treatment manuals and practice elements is something we've certainly discussed previously. But if we think of if we think about evidence-based chocolate chip cookies, we might be looking towards the recipes that have been well established, have undergone rigorous kitchen testing, and have a high quality product. We know what we're going to get. So just for example purposes here, I have just the ingredients listed for Betty Crocker's Whole House, New York Times, and then I realized today I actually don't know how to pronounce this word very well, so my apologies if I'm not saying it right. Ghirardelli or Ghirardelli, I don't know how to know what the appropriate pronunciation is there. But what we could see, we could also almost consider each of these different recipes as like a manualized treatment approach. So if we were talking about treating a kiddo with disruptive behavior, we could easily replace the words Betty Crocker's Whole House, New York Times, and so on and so forth with things with commonly known, well-established evidence-based treatment manuals for the youth concern. So perhaps Barkley's Defiant Child, Triple P, PCIT, and so on and so forth. But what you can see here is that within each of these recipes or treatment manuals, there are some common approaches that are being utilized or common ingredients that help to make up that specific recipe. And you can see that there's actually some variation though. Obviously, the big name brands have some sort of big name chocolate that you're supposed to be using, but there's some variation in terms of some of the ingredients, while there's also some consistency. So we see that most of the recipes call for flour, call for butter, some 1 egg, some 2. I'm pretty sure I think it's this New York Times recipe, they make you get baking powder and baking soda, not just the baking powder. But there's also certainly those common elements that make up these larger strategies or recipes in a similar way that we have practice elements are common discrete intervention strategies that help to make up larger manualized treatment approaches. Okay, so that's great. We see what's these well-established recipes, but I know we all also have a mom or an uncle or a grandma or a bakery down the street that may offer our preferred local recipe. And typically that is a well-established local recipe as well. So this, I actually sent my mom a text message this morning. My mother is a well-known, I don't know that I would describe her as a well-known baker. I would say though that people really, really like her cookies. And in particular, her chocolate chip cookies are very popular. So her additional elaboration on one of the recipes I just showed you is to melt some chocolate chips in the microwave and then add them to the cookie dough. Apparently this requires some additional flour. There's a very specific measurement technique. I don't know if you have a custard cup in your kitchen. If you don't, good luck replicating this recipe. But this would be an example of a local variation that, at least within my Ohana and friend group, has been well established and been shown to be effective for our taste buds. So, but given this, we might also be wondering, when we're trying to bake ourselves, and if anybody has been on Pinterest, you know how overwhelming it is given all the options out there. what we might do to try to synthesize and really put these pieces together. And so that's exactly what we're trying to do with the tool that I'm about to introduce to you next. Often we have an understanding of what the core elements of treatment are within research studies. And we also know that there are some certain strategies that work for our local kids too. But how do we put those pieces together to really help to guide and inform the work that we're doing with our youth and families? One more thing before I get to the tool. In order for us to be able to synthesize those pieces of information, it's really helpful to have some common language that we're referring to. And so this is where it can be helpful to just have a reminder about what treatment targets are and what practice elements are. The treatment targets are the strengths and the needs that we're addressing as part of youth mental health services for kiddos and families. So these are things like the major problem areas or issues or again strengths. This might be something like positive family functioning or oppositionality or depressed mood, for example. Additionally, in addition to being able to identify those common issues or concerns, we also want to know how to address them and have a common language to speak to that piece of services. And that's where the term practice element comes in. So these, again, are those discrete clinical interventions. So perhaps something like praise or time out that are common to manualized approaches that may be applied by the therapist or the treating provider within the context of a treatment session. And thank you, Tommy, who just dropped in the chat our treatment target progress rating and practice element code book for your reference. So this is an example of a tool we developed called Practice Element Matrix, which helps to synthesize both those treatment research findings alongside our local aggregate data for kiddos. I'm going to break this down a bit next, and we'll walk through then how we might go ahead and use the tool. So to give us a better understanding of the local aggregate piece, what we did was we took a look at CAMD youth who received an initial treatment episode that was at least 90 days across a 10-year period. We examined 5 major levels of care within our broader system of care. Those included intensive in-home, multi-systemic therapy, functional family therapy, our transitional family home service, as well as community-based residential 3. And again, we included those youth who just received an initial episode within that level of care. There was a slight difference of youth that we explored for intensive in-home, given that so many of our youth enter our services in IIH. So we only included youth in that level of care if they were also CAMD naive youth at the time. What we did was completed multi-level modeling to examine treatment target progress as a function of whether the youth received a particular practice element during the episode when common targets of treatment were also endorsed. So whether a specific practice element and treatment target were endorsed within that same episode. And we took a look at the first 6 months of treatment services and the progress that youth made by that 6th month. What we did then was organize the information we got from our local analyses alongside what we know from our treatment research findings. So I'm going to break all of this down for you next. But just to orient you, what we're seeing here is the practice element matrix for youth in intensive in-home who receive the target oppositional or non-compliant behavior. Essentially, when using this tool, what you'd want to do first is go ahead and search for your level of care and treatment target. And what you'll notice is that the practice elements are organized and also color-coded in descending order based on their strength of evidence for both the research and local data, but research data is prioritized. Practice elements were included here if they were present in both the research as well as the local data. And I just mentioned that because there may be other practice elements that were present in one that, but not the other, that may not be here in this tool. What you can see here, so on the furthest left column, you'll see the correspondence between research and local data that's organized by and actually color-coded by rows of practice elements. So practice elements are grouped based on whether or not there was high research and local evidence for them, whether there was high research but limited local evidence in yellow, limited research but high local evidence in orange, and limited evidence for both research and local data. The second column includes the practice element name. The third column then includes this percent in research protocols column. This indicates the proportion of studies that the practice element appeared in treatment research protocols. It's important to note, I had talked earlier that referenced earlier that we looked at multiple levels of care, and the research evidence across the levels of care is identical. Finally, then, the rightmost column includes the local evidence, or beta score, which is a statistic that reflects either the increase or improvement or decrease in estimated treatment progress associated when there's been one or more instance of the co-occurrence of the treatment target with the practice element during the episode. So for this example, that one or more co-occurrence between problem solving and oppositional behavior during the episode. You'll notice that a couple of things. One, that because of how these are grouped, they're grouped by the median split, which was used to determine areas of high or low correspondence or association between research and local evidence. So what that means is that there are times where there may be a negative beta that's present alongside a practice element that had high research support. It is something that is important to consider. The other thing that it's important to know is there are a couple of notes on the bottom, just a reminder what I said earlier about the beta reflecting an increase or decrease in estimated progress. And you'll note here that the research protocol data is based on 145 study groups. That was this information all came from Practice-Wise Evidence-Based Services Database, was used as a reference for these research protocols data. I made mention of this before. This is just for your reference. Again, being mindful about how the tool is organized, such that the practice elements with higher evidence for both research and local data are at the top in green, and all the way at the bottom, we've got in red PEs with limited research and local evidence, yellow and orange in between. Okay, so we talked a bit about different types of evidence you might be using, you might be able to reference during treatment services, as well as how to reference, to take a look at the tool. But you might be wondering then, so given all of this information, when might I actually use this in treatment services with my kiddo? So there are a couple of different time points you might want to consider using this tool. The first is right at treatment start. So you may be examining the tool to identify what practice element to use both right when you're initiating treatment and potentially even through the course of services with that kiddo. For youth who have more than one concern, you might be taking a look at each of the treatment targets and trying to you intend to focus on, and trying to synthesize or identify some common practice elements that appear in either the green or the yellow rows across those targets. And you'll want to, again, be considering both the research and local evidence for both. So I have an example kiddo for us here. Just when I switch to the next slide, I'll give you more directions, but just get ready to be thinking a little bit and chiming in your chat box to using that all panelists and attendees option again. So I have an example kiddo. So we are going to be providing treatment services to Brian. He is a 12-year-old male. He has both depressive and anxious thoughts, feelings, and behaviors. He's been referred to us for intensive in-home services. So thinking about this, then how might you use this tool? What are some of the practice elements you may select for Brian, our anxious and depressed kiddo? So first, you might go ahead and select as your level of care intensive in-home. You might then identify the practice element matrix for both anxiety and depressed mood for our kiddo. And glancing through this here, I know it's a lot of information, but pop into the chat and let me know what practice elements, just one, maybe two, you think you might start off with for this kiddo, given this information and given that you know you're treating a comorbid concern. What do folks think? Okay, I see insight building, cognitive, guided imagery. What else? Anything else? Self-monitoring, relaxation. Okay, got it. Lots of things. All right. So problem solving. Okay, so great. Exactly. And folks can keep chiming in if they'd like. So some of the common PEs you might be looking towards are cognitive and problem solving. I think looking at anxiety and cognitive, we see present in more than half of the research protocols. Also, we see a positive beta here. Similar with cognitive for targeting depressed mood. This practice element was present in 71% of research protocols, also has local evidence for the practice element as well. Problem solving similarly was present in for both anxiety and depressed mood. I think this one we find something slightly different. So actually here in depressed mood, present in a lot of protocols, smaller and actually negative beta. So just something to consider, but probably wouldn't necessarily mean that we, again, we wouldn't apply this practice element, because we do know that it is frequently occurring within the treatment research. And similarly, also we see for kiddos with anxiety, potentially in less protocols in the treatment research, but high beta for anxiety. There's a couple of others here too. I think relaxation is another one folks identified as appearing in both. And then I wanted to talk a little bit about the guided imagery. This is something really that I think was really interesting in terms of completing this study, because we found that this was a practice element that seems to be offered quite often actually for our kiddos for Depressed mood, we see that present in maybe a little less than 20% of treatment manuals, got a higher beta here, but not very often in research protocols for anxiety. So just something to be considering when we're selecting these practices. And potentially we would start with those that do have higher frequencies in the treatment research. Given some of the limitations of the data and of this study, we've organized this tool in a particular way to actually prioritize what we know about the treatment research and something to just be mindful of there. Okay. I should have mentioned this earlier, but folks, if you have questions, feel free to drop them in the chat or the Q&A too. Okay, so another time point, in addition to treatment start, that we might be using this tool is an ongoing case review. So this might be in case review or supervision, and some of the time points that we might be taking a look at this tool at are when a case is not making the progress that we're expecting, when we've exceeded our average length of stay within a particular level of care, or perhaps when a case is nearing a point of diminishing return. So really when we're not making progress, or when we have some of those other clinical indicators flagging that indicate we are really not where we would like to be in services with the youth. Okay, so we got our same kiddo. We are 7 months ahead of where we were 5 seconds ago. And now Brian is in his 7 months of intensive in-home services. Apparently, he is still presenting with depressive and anxious thoughts, feelings, and behaviors. But now we're 7 months into treatment. And it sounds like we have not been making a lot of progress. So how might we use this tool at this point then? I'll flip to the practice element matrix in a sec, but one reminder I wanted to give everybody is that when we think of some of our other indicators for CAMD services, our average length of stay in intensive in-home is about 8 months, with most youth actually reaching that point of diminishing progress by their 6th month of treatment. So we've got some indicators here that are really telling us, hey, we need to figure out a different strategy for Brian's treatment services. Okay, so again, 7 months of services, concerns are anxiety and depression. So taking a look at this tool and just thinking about his services big picture, what might we be suggesting for Brian? And folks, you can go ahead and put your thoughts in the chat.
Pua, there's a question from Leslie.
I see it. I'm going to come back to it. Leslie, I got you.
Okay.
Don't worry. Thank you. So go ahead and drop in the chat thoughts you have about what we should be doing for Brian, who's in his 7 months of treatment. No right or wrong answers here, folks. Yeah, so exactly. Lots of good ideas here. This might be a great time to, and granted, this is a hypothetical kid with very limited information we're trying to make some big clinical decisions about here today. So one thing I think that Kurt is really saying that's important here is, using these as a reference to identify a practice element that perhaps you didn't try before, or that wasn't used within services at this point, but might still be relevant based on the clinical needs for the kiddo. So again, for our pretend kiddo Brian, we know he's pretty anxious, pretty depressed. Maybe we've had him in services for this long and he continues to experience a lot of anxiety-related impairment and a lot of avoidance. And maybe we haven't done exposure with him yet. If that's the case, referencing these tools, it's probably a really good idea that we're heading in that direction soon, given his needs. I see some other suggestions about specific other strategies that might be implemented for this kiddo. Maybe these are ones that we haven't done so far. Self-monitoring, maybe we want kiddo to go ahead and really keep track of what's going on, use that data to be able to help us make adjustments to treatment services. And maybe this could come up, I think, as the strategy that we had talked about when we were talking about treatment onset, but maybe there are some other approaches consistent with both concerns that we haven't been able to, for whatever reason, we haven't chosen to address yet, and maybe practice elements we want to try at this point in treatment. So I think the biggest take home here is that this is certainly a reference to be able to help us determine where to go next, and if there and can be used as a guide to identify whether there is a need to change treatment direction, given what has already been applied for the kiddo, and what strategies we may still want to be considering. Okay, Leslie has a really good point on in the chat here, and clarification question. So Leslie's asking, these are PEs we might put on a treatment plan, but not necessarily first things we would do in the first session. We may base the order of PEs used on research protocol. So exactly. So what these may not be things we're jumping into at our first treatment session, but these are tools that may help us identify practice elements that can help us organize our approach through the course of the episode, or things we might want to prioritize shortly after treatment onset, also given the areas of concern identified for the kiddo. Folks, if you have other questions, please drop them in the chat too. Okay, so today we've talked about several things. We've talked about different types of data that we have at hand that can help us to support our clinical decisions. So research and local evidence, our case-specific data, as well as our causal mechanism data. We've talked about a tool that helps us to synthesize research and local data to inform our clinical decisions. And we've had a little bit of practice using that tool. Before we move on to our discussants, however, I just wanted to also show you all how you can access this tool yourself. I know Tommy dropped it in the chat earlier. This is the CAMD website. I do have a link here, but you can actually just you can see all the chocolate chip cookies I was Googling earlier today. Okay, you can just Google CAMD, C-A-M-H-D. It should be the top link that pops up. What you'll do is you'll go to For Providers, and you'll scroll down to Clinical Tools. There are several different resources here. Actually, two of them we provided for you today are at the top here, and you'll get to Practice Element Matrix by clicking on the link there. You can make it big. You also can download the PDF here. This function that I wanted to tell you about, though, is that this is actually hyperlinked, and it should be hyperlinked when you download it also. So what that means is this is a very long document, but if you know, hey, I want to, for my kid Brian, my depressed and anxious kiddo, let me pull up that that intensive in-home depressed mood treatment target. I can actually click right there, and it'll bring me to the specific page I want to see, and then I can use the scroll bar on the bottom to help me get back to start. The other thing is that the first page of this tool also provides a lot of the orienting information that I shared with you earlier today as well. Okay, folks, so thank you so much. I think slides will get sent out later. I do have resources linked for you also. Thank you so much. I know we're excited to hear from our discussants next. Thanks, everyone.
Thank you very much, Pua. Yes, so now, if you've been to any of these roundtables before, it's a pretty informal, free flowing kind of thing. So what we're gonna do right now is I'll introduce our esteemed discussants. And from there, we can go in a variety of ways. Discussants can give their initial reactions or comments. Other panelists, such as our CAMD leadership here on the call, um, Dr. Shimabukuro, Hernandez Armstrong, as well as Humphrey, can give their perspective and input on a variety of things. We can go question and answer from the audience. It's a pretty free flowing sort of thing. So with that in mind, without further ado, our two esteemed discussants, we have Dr. Bill Sheehan, who is a board certified child and adolescent psychiatrist working at the Department of Health, Child and Adolescent Mental Health Division, Honolulu Family Guidance Center. He has practiced adult and child psychiatry in Hawaii in a variety of settings for the last 37 years and has been with the Child and Adolescent Mental Health Division since January 2017. And so welcome, Dr. Sheehan. Thank you very much. And also we have the pleasure of having Ida Bonilla, who is the school-based behavioral health educational specialist in the Office of Student Support Services for the Hawaii State Department of Education. For this position, she provides leadership, technical direction, coordination, and consultative services statewide required for implementation, planning, and sustainability of a full spectrum of behavioral health services to meet the needs of students at all levels of the Hawaii multi-tiered system of supports in all schools. Prior to her current position, she also provided SPBH direct resource support at the DOE Windward District Office and was a school-based behavioral health specialist for 15 years at Kapunahala Elementary School. Welcome also, Ida Bonilla. Thank you very much.
Hey, Brad.
Yes. Yes.
Does all the participants have the ability to unmute themselves?
I don't think so. Not within this panelist type of format.
Okay.
I don't think so. I think everybody can give the on the chat.
Okay.
I think. I mean, we can try. Yeah. Unfortunately, with this type of, sometimes if we have like over 100 people, it would be kind of
Right.
whatever. I'm not too sure for today though. I mean, it would be great if we could. I know we have a lot of our leadership in the room as well too. Yeah, sorry about that, Scott. But yeah, it'd be great if somebody could try to do that. Let me know, anybody. I see Leslie and a lot of other friends, Andrea and a lot of other friends in the audience, Kimberly McDonald and so forth. Yeah, so maybe we can turn it over to Bill and Ida for any initial thoughts or reactions or questions to Pua.
Well, good afternoon, everybody. Bill Sheehan here. Dr. Nakamura, as I get started, just give you a couple of minutes, and is there any general thing you'd like me to comment on? A very, very excellent presentation, as always, Dr. He. Thank you. I appreciate it, as I learn something every time I listen to you, so thank you. What would be helpful to the group, Brad, that I could make a comment on?
Oh, any direction that you like to go, and then maybe we can hear from the audience on the chat as well. So maybe Bill, you can start us off wherever, and then it would be lovely if the audience and friends or panelists could just also
guys,
give their thoughts on.
Thanks. This is helpful, and I appreciate it. I'm really glad to be here today. I see a lot of people's names on the side, and some I recognize, some I don't. So I'm going to guess it's a cross section of clinicians in various degrees of training. So I can only share it to you from the 38 years in the practice, where I used to use paper and pencil to make all my notes, kind of like that. That used to be our patient notes. Now, what I've listened to you, Dr. He, present on this several times in the 5 years that I've been here. And each time I get an incremental benefit to my understanding of how this is meant to work. And so I know those of you coming up in early in your career right now are going to get this. And you're going to grow up or get in the career, and you're going to wind up being like I am now. And I'll remember back to paper and pencil, and you're going to remember this. So it's generational, I think. So I appreciate you inviting me to because I am learning. My neuroplasticity is still there, but it takes a lot more effort than it used to. So I think this has got legs. It's catching on. It's intuitive. I think we are going to continue going this direction. It's just hard to integrate it. It's like hard to integrate it while you're actually. It's like trying to change the flat tire on your car while it's still running. You can do it, but it's kind of hard for a guy like me. So I think those of you just learning this as you come up in the field are going to be at a distinct advantage as you integrate this into your practice as you go along. So I enjoy it, and I'm looking for, so for me then the practical implication of this, like at my job at HOFGC, at utilization management reviews, at treatment teams, at reviewing cases, integrating this live time while we're actually doing the other things that we do is proving to be a challenge. How do you add it in, if you will? Instead of growing it up together, we're trying to add it in as we go. That's a hard way to do it. So I think what the future holds is integrating it in people's training. They'll grow up with it, if you will, and it'll be integrated into their treatment. And here's the last point before I'll turn it over to my colleague here, Ida. But last year, the division gave us some discretionary funds to use for continuing education. I bought PracticeWise. So that's how I used my money. And me and Shara Moranaga sat here looking at that thing and trying to educate ourselves on how to actually use it. And I probably needed a tutor. It was a challenge, but I'm intrigued by it. I enjoyed it. There's a lot of good information there. I think that the integration is going to be a challenge for people like me. So I'll just leave that with you. Thank you.
So I know we want to hear from Ida also, but Bill, if I could just reflect on a couple of your comments, and I always so appreciate your feedback on your thoughts. And I think we know that really across the settings, I think you and I are both here today from CAMD. We have Ida here from the DOE. We have the pleasure of working with clinicians across a wide array of background and training and strengths and growth areas. So I think that I really like what you were saying about some of the practical implications of really when we might use the tool. And I think this is even going beyond some of the suggestions I had today in terms of thinking about, really being able to use this as a reference in the context of treatment team meetings or even utilization management for kiddos also, in addition to specific case review time points. I also definitely hear what you're saying about the difficulty really and the need to further explore the integration piece. I think of one of our other colleagues who's actually here today, whose comments I'm going to just borrow a bit, where, thinking of, I think, the wave of the future is also trying to integrate this information at hand at the time that we're trying to make some of these clinical decisions, whether that's within our electronic case management system or some sort of other flag that would pull this information into being easily accessible for us. I will say for me, and this is still the maybe the electronic paper version of that, as I just have multiple tabs open, sometimes on multiple screens that I can reference side by side in order to be able to use the tools without them being integrated directly at this point. But I appreciate all of your thoughts on that, and kind of look forward to continuing to explore these things together also.
I think I'll take this chance to jump in. First off, I want to say great presentation, and it's been fantastic really kind of joining you on your journey as you've been developing this. I want to thank you for collaborating with the DOE and inviting us to the table so we can see how you folks are developing the use of this data and how you're implementing it and integrating it within your system. Because I'm borrowing a lot of it from you. And I think for us, hearing some of the things that you're trying to accomplish, I've been grateful to kind of take those learning lessons. And I think some of the points, and I still use my paper pencil, I think it's going to be hard to move away from that, but it brings up a good point in really trying to align all the tools that we use within our systems. And I think that's going to be a piece to navigate so that folks are open to incorporating the new practices within what they do on a daily basis. Because if there's too many different data collection systems and different offerings, then they'll choose one, and then our data continues to kind of be all over the place. Another thing that kind of came up for me and for SBBH, we're definitely leaning towards PracticeWise and offering that to our staff, is looking at the number of different kind of professional backgrounds we have and establishing some kind of baseline understanding of the different elements. And so like when Dr. Sheehan mentioned that implementation support, and this is something that I really appreciate Brad supporting us in, is that you can offer the tools, that's one level. Here you go, here's some resources. But the other piece of it is once you offer those resources, to ensure there's that support that's available, so that not only do you have an understanding of what those elements are, is that people are offering them with fidelity. Coming from these different program areas and practices, when they mark, guided imagery, is everybody offering that to the same degree, so that when you look at the impact of that, is it aligned, and can you really judge them from, and for you folks, I imagine it's a bigger struggle. You have different agencies who train in different ways. So figuring out how to kind of get everybody on that same baseline, so that when we're offering those elements, we're all offering it the same way. And I think some of the other pieces that come up is really looking at, for us, long-term, right? That alignment between DOE and CAMHD, and then all of us kind of having that similar language. And as we introduce these practice elements, that collaboration on student cases, I really look forward to our providers being able to speak to the same elements and the same responses in the same target areas. And so either when we're collaborating on cases or doing that warm handoff, it's not a start over, right? And our families will be exposed to the same language. So I think it'll really impact our ability to kind of have this continuum of support, and not this need to start over with data collection and implementation.
It's really exciting to hear about all of the things happening in DOE right now also. And I think the movement towards shared language between our systems is probably something selfishly I am most excited about. I really look forward to continuing to hear about, kind of more the clinical efforts, but also the efforts you folks have around your app being developed also. So exciting stuff. Thank you, Ida.
I just wanted to comment that what Ida was saying about doing that, making sure that people are offering the same thing, even though they're calling it something. They might be calling it the same thing, but is it really the same thing? I think that is a struggle that we have, and something we'll have to continue to work on. I think that that's an issue everywhere. But I'm glad that you kind of are seeing similar things. Like you said, different levels of training. And for us, it's different providers and trying to figure out how do we overcome that and make sure we're speaking the same language. So it's nice to have PracticeWise. It kind of gives you a lot of clarity in that, and just having people be able to access all of that, and that we're able to do some trainings for our providers. It's been, I think it'll be very helpful, hopefully.
Yes, any questions and comments from the audience as people are thinking? Oh, got one from Dr. Leslie Slavin. I'll just, looks like everybody can see it, but I'll just read it out loud. So I think, well, for the recording, I think, yeah, for the recording, people will not have access to the chat. So I think most of us were trained to focus greatly on the therapeutic alliance to figure out how to have a strong relationship with the client and family. I think this work pushes us to focus also on what we are actually doing with them to provide needed skill development and bring about behavior change. So I think this material can help with finding a good balance for many clinicians. Thank you, Leslie. What do you want to expand on that?
I think that is part of the challenge, is kind of like in a supervisory role or kind of as a clinical lead. How are you helping the clinicians? Because I think most of us here on the panel are supervising the clinicians versus doing more of that direct care, helping them to see, yes, you're building great alliance. That's great. Let's talk about the other things that you're doing. So as a clinical lead, kind of checking in with the therapists and making sure, okay, I see that you took them out, you're trying to build rapport. How are you trying to work on these elements that you've identified that you're going to work on with this kid? So I think that that's something for us as clinical leads, and within our division, we're going to have to work on doing a little bit more. And if there are providers in the audience, I'd love to get feedback on how we can do that in a helpful way, or what their thoughts are about this, because I think it's really, they're the ones who are delivering all the services, and knowing the challenges that they face is helpful to hear kind of, well, yeah, I tried to do this, but it was hard to do for this or that reason. So I'd love to hear feedback if there are any providers in the audience.
I'll share with you guys, we had a really serious sentinel event about a year ago with one of our youth from the Honolulu Family Guidance Center. Did a root cause analysis on it, and as part of that, one of the root causes of this thing that we identified was lack of engagement. And looking back on it, and I'm just flashing what you're saying now, Jamie, that and even Dr. Slavin, even though she's retired, she's not really retired. It's in her blood, I can tell. Nice to see you, Leslie. So basically, what this treatment alliance, we do a lot of focusing on that. One of the things that we're just not struggling, learning, is how to, we can more easily identify low and medium engagement rather than full engagement on both the youth and the family's part. How do you change that level of engagement? What do you do? Well, one of the things coming to me, Pua, is that possibly if there's a gap or a mismatch between patient, family, youth's needs and services being provided, maybe they wouldn't be engaged because it's not exactly helpful to them. I don't know, just kind of brainstorming here. And that a better match perhaps between the need of the individual and family and the practice elements or treatments to be offered, or aspects of treatments, even if they're delivered by intensive in-home, you can do those elements. And maybe that would make a better match and a better engagement, which would lead to better outcomes. I don't know, something like that.
Yeah, so lots of things to consider, I think, certainly. And, kind of putting together some of the different comments from, Leslie and Jamie and Bill, you also, I think, a couple of things come to mind for me. One, sometimes there is potentially an overemphasis or over-reliance on, certainly important therapeutic alliance, but at the risk of not focusing on actual skills with kiddo throughout the course of treatment services also. And so I think these tools can really help to align some of that a bit more and help to organize what we might be focusing on within the context of the treatment episode. The other thing is, and the reason I really started today's talk with a reminder of some of the major types of data we might look to inform our clinical decisions is that sometimes we also have a bit of an over-reliance on clinical judgment as well when we're trying to make decisions about a client. and about services. And that can be risky because you know, as humans, our decisions and can be biased and faulty also. And so it can be helpful to look at all of these pieces together as we're making a decision, so that we're not at risk of maybe emphasizing one at the risk of not considering another also.
Other questions, either from the audience or panelists, for anything people want to share?
I was gonna share a little bit some of my thoughts because I love this tool. I think it's gonna be so helpful in guiding clinically the management of cases, and I do think that any tool is kind of as good as the person using it, or it's as useful as yeah, it's as useful as the capability of the hands of the person who's holding the tool. And this one is a really good one. It reminds me to stop and think and not take for granted that I think I know what's best for this kid, and what's like it's a great way to kind of go back and sort of check your thinking to see like are the practice elements that I would have picked just right off the bat, are they actually showing up in the research evidence? Are they actually showing to be useful in our local data? At the same time, I don't think it doesn't tell the whole story or solve every issue. I think about this fake patient Brian, who he had the depression and anxiety, and it lasted for 6 additional months or whatever after treatment started. Poor guy. I'm thinking this tool, it doesn't say anything about consider maybe placing Brian on an SSRI. Like there could be a medication that would be evidence-based and really helpful for both kind of depression and anxiety. It doesn't really say anything about like, has anybody checked Brian for like any kind of medical comorbidity? Maybe he needs his thyroid checked, or maybe he's a 12-year-old boy, maybe he's having some kind of pubertal issues, or who knows. There's all kinds of things that run through my mind when I'm seeing treatment isn't working, right? And so it's, to me, it's at least helpful to have one tool that you can turn to when your mind is kind of racing and you're trying to think, how can I help this kid? What is going wrong? What needs to be done next? At least you have one thing that you can kind of turn to for guidance, to try to help you kind of figure out what the next step should be. What didn't you try? What works that you didn't try? And so I think that if we're putting this tool into the hands of the CAMD clinical leads who have all of this, like Dr. Sheehan, the years of experience, the medical knowledge, the desire to meet with patients and engage with them, and if they're not engaged, work on engagement with them. It's a powerful tool, I think, to put in the hands of an expert clinician like Bill Sheehan. And so I'm just really excited, to kind of see how far we can kind of go with this. So anyway, that's sort of where my mind went during the presentation and hearing the panelists.
Thanks, Kurt. I think those are all really important points, both in that there are strengths to the tool, but there are also limitations, right? This tool is not going to tell us like, hey, we may need to get a medical evaluation on this kiddo to see if there's some sort of kind of physical health impairment. You mentioned thyroid that might be getting in the way and driving some of the mood concerns. You also mentioned, and a good point around, do we need a psychiatric evaluation to see whether medication is appropriate? And I think this really also speaks to where it can be helpful to use this tool in the context of supervision or case review also, where the parties that are meeting can really explore the pieces of information we can draw down from the tool, but also can be cognizant of some of the other factors that we might need to be looking at when we consider what needs to happen when we're considering a pivot in treatment services also too. So certainly one piece of data, or pieces actually synthesized, but one tool that helps us to organize some pieces of information while acknowledging that there are others we may want to be considering for our clients as well. Also in the chat, I think Melissa provided a really good comment here. Scott Miller and colleagues using the term deliberate practice to integrate therapeutic alliance, so outcome ratings, session ratings into clinical decision making, that are pretty consistent with some of the tools we're discussing today. And Brad has mentioned that this is also really a data-driven way to keep track of therapeutic alliance, and is consistent with that case-specific evidence that we talked about earlier today too.
I could jump in on something.
Go ahead.
Sorry.
Thanks,
Dr.
Anna.
was sharing is that the importance of having this tool and utilizing it within a established system that is has a process of utilizing data to make informed decisions to drive the interventions and supports that you're offering. And the hope is that that system that exists really looks at the kiddo in this whole child approach, right? So that school teams for us, for the DOE, come together and really are looking at all of those different things that impact a student's ability to respond to a treatment, or just a student's ability to progress, right? So it might be a spot on treatment, but there's all these other factors, like you were saying, that may be impeding that progress. And it's really up to the people, right, that are supporting that student or that child to really take the time to really investigate all of those other things, so that when we utilize these best practices, they're as impactful as they can be. And the other thing, now I'm drawing a blank, but I think for us, is the data we're providing clean too. And I think some of the systems that we're hoping to put in place, some tools we're hoping to put in place, are to collect really what is everybody doing. And so for SBBH, we're hoping to move into a system that in their service logs that our direct providers are utilizing, they'll be marking, okay, I'm using these specific practices for these targets, so that we can start collecting that same data that DOH is collecting, so we can see, okay, what are the local practices that folks are choosing compared to what the recommended practice-wise elements, and what is the impact of those. And previous to now, we didn't really have a system to really collect all of that data, but moving forward, hopefully we'll have that, and we'll be able to start tracking what's going to be effective for our students within our DOE system.
Thank you, Ida. That was really, really great to hear about the coordination and the infrastructure. Very exciting times in terms of partnerships with CAMD, as well as you talked about trying to standardize a variety of metrics. So very exciting things coming soon. One thing, looking to a comment from Don Martin, talking about how she just says, we just attended the PracticeWise training and it was very helpful in understanding this tool. The clinicians that attended from our agency also really appreciated the step-by-step use of the treatment targets and elements and how we can gauge progress. Very useful. I would love to learn more about collecting data and using data to help, but the resource guide is really something that helps all clinicians, especially new clinicians, as a starting point. So maybe I could turn it over to the group or panel with a question, maybe an irritating or provocative question. Is I am hearing a lot of evidence and data sources and 4 evidence bases, and it sounds like is there a risk of having too much information? Any advice about coordinating or prioritizing evidence bases, or what are people's thoughts on that?
We had a really interesting discussion just a minute ago in our clinical lead meeting about use of data, and we were just talking about, are we actually measuring what we want to measure with this information? And I think it's always important as a clinician and just generally as an agency to think about that, because we can easily get bogged down in, oh, we have this data and this data and this data and this, look at all this data, you know, and it seems really great. And it is great, but also making sure that we're trying to measure those things that we actually want to measure. And so I think it's good to continue to check in on those things, especially as you get more data and more information. And that if we're missing a part, that doesn't necessarily mean that we need more and more data, but maybe we need to figure out how we can make a better use of the data that we have, or streamline the data that we have. So I think it's an important thing to consider and keep in mind. And that takes all the great minds that we have in our community to make sure that we're checking on that. But it's certainly something that I think comes up a lot for us, because we do have access to so much great data.
Hey, I'll bounce off of that, Jamie. One of the things that I think we do here a lot, just in our Family Guidance Center here, guys, is we really focus on episode of care model. And generally speaking, look, by definition, who gets into our system is somebody with a diagnosis, a qualifying diagnosis, and a high CAFAS score. Okay, so they're already a couple standard deviations past the mean. We don't expect necessarily they will be cured or resolved or not need services anymore. We focus more on that episode of care to get them from wherever they were to where they don't need this intensive kind of level of care any longer. And they may need ongoing care in the community, but we're trying to finish that episode off and then wish them well and transition them to someone in the community if they need follow-up. Great if they don't, but if they do, it's out there. So this kind of material helps that, I think, helps guide that, hey, you know, these things are the ones you came in with and we identified that were the real bad ones are better. But yeah, you do need ongoing, that's appropriate, but let's refer you back to your health plan, find a provider in the community who can help you as needed, something like that. So I kind of think that's something we're trying to focus on, episode of care versus just care in general, and then get that concluded and refer, if needed, to the next lower level of care.
I think just one other comment related to that and what Jamie and Bill said, and hopefully tying it a little bit to Don's great question, is just that I think we want to be mindful and prioritize what we're tracking for our kiddos, particularly when we're considering that case-specific historical information. In CAMD, we do have 3 explicit measures standardized measures that we use to help us track progress over time. I referenced one of them a little bit earlier today. So the CAFAS, the Child and Adolescent Functional Assessment Scale, that's administered quarterly and completed by our care coordinators. We also have a client's report measure administered monthly to youth and separately caregivers. That's called the Ohio Scales. And then, and I know we have several providers here today, but our providers also indicate the targets they use during sessions, the practice elements they use to address those targets, and the associated progress ratings each session of treatment services also. And so we really want to, in CAMD, I think we're looking at those three measures most typically. That being said, though, a provider might also be tracking something that's more idiographic to the client, and may have a more tailored measure that they're completing at some sort of routine basis also, that may be more centered on the client's needs. So for Brian today, who had concerns with anxiety and depression, maybe the therapist working with him was tracking mood ratings. Maybe if they were completing exposure, maybe they were tracking fear ladder ratings, and maybe they were doing a more targeted standardized assessment to capture those symptoms also. So Don, I see your comment. Sure thing. So targeted measure that take a look at the symptomology for anxiety and depression. So maybe something like the RCAD. So I think we want to be cautious about how much we're asking of youth and families. We want to also be mindful of prioritizing some of our measures. And I know Ida spoke a little bit about their system. I will just say for ours, I think we have a lot of data, and I think that some of our next steps at CAMD are also really
Uh-oh. Cliffhanger. She did that on purpose. Our next step is.
I'm holding my breath.
Oh, there we go. Pooh, you cut out after you said our next step is. Oh, even she did it again. In suspense. Good thing this is not being recorded and put on YouTube somewhere. No one ever will forget about it.
So to really try to synthesize those different pieces of information to help inform our clinical decisions.
Here's an idea, you guys. I was just thinking about our clinical management plan. So at the beginning of the episode of care, we make a clinical management plan, and as part of that, we identify treatment target options and select those. Every month in the utilization management review, we review them. What if we added drop downs for all the practice element options that we could select at the UMR, and then route it back to the level of care, wherever they are? They can see that every month too, that we, through our internal utilization management review, has identified there are some practice elements that may or may not be used, and we'll suggest them to you. Something like that. I don't know.
Yeah, I mean,
I
think that's a good, because it ends up happening anyway. Like as a clinical lead, I'm always like, did you try this?
Right.
And if I had kind of, because I think sometimes we have really difficult kids. I mean, that's we are a carve out for kids that are struggling the most. And I think that's part of what we do as an agency, is try to support those providers in doing that care. And I think if we had kind of this, hey, we have this list and here's some possibilities to try this, and what can we do to support you with that? And I think for the most part, our providers are like, thank you, like that's a great idea. I think we have, when we have good relationships with our providers, I can also see them saying like, we're gonna do how we want to do, don't tell us what to do. But I think for the most part, we have pretty good relationships, and they're open to feedback, especially when a kid's really, really struggling and you kind of get to be at a loss for, I don't know what to, and you can go through it with them together and work.
Well, Jamie, that's a good point. What I was thinking is that we all stakeholders in this. So that the intensive in-home therapist, or every level of care, the people providing that treatment, I want them to know all these things, and I want them to have access to that. So it's, maybe it is something that would be a next step. I don't know what folks think, but I would like the intensive in-home therapist to be able to see these things, and they may or may not. If I'm sort of still learning on the learning curve here how to do this, they may not even be on the curve yet, or just getting started or something like that. So maybe something to think about.
Yeah, I think
All right.
I'm
I'm
just
sorry, go
looking
ahead.
at Leslie's comment, and that's kind of what I'm saying too, is like, we want to give them leeway to, as a provider, do things how they feel like it's going to work, but also providing support and consultation. It's a fine line. We have to build rapport with our our providers as much as they need to build rapport with our clients. So, yeah.
You know, the CAMD buzzword around that is co-managing care, right?
Right.
Yeah.
Okay, thank you. Thank you, everybody. A wide variety of very wise and experienced perspectives shared across the board. Maybe we could turn it to Pua or one of our both panelists, one panelist, to kind of close it out. Anything in closing, Pua, Ida, or Bill?
Just thank you, everybody, for all of your thoughts and questions and feedback today. Bill and Ida really appreciate, and Jamie and Kurt really appreciate hearing all of your thoughts and all of the thoughts from the audience today. I think that the information on this tool and the slides will be sent out later, or will be available for you actually probably on the Hope You're Taking website. And don't forget, go to the CAMD website if you'd like to take a look more in depth at the tool. Mahalo, everybody.
Thank you very much for inviting me. I'll just leave you with the famous words of Pink Floyd when they said, all in all, it's just another brick in the wall. So carry on. So this is another brick in our wall. I was at that concert, by the way. 78.
How do I follow that? I'll just say thank you.
Thank you, everybody. Have a great day.
That was fun. Thank you. See you guys around.
Bye.